Okay, Josh, could you tell us a little bit about yourself and how you got to this stage in your surgical career and where you've been?
Sure. So I'm from Hamilton, Ontario. I did my undergrad at Kamstra University in Health Sciences. During my undergrad, I became passionate about global health and health equity. That's been sort of a focus of mine since then. I did my medical training at McGill, and while I was there, I started doing some work with Tarek Razik in trauma, looking at the validation of trauma scoring systems for low and middle income country settings. During medical school, I also had the opportunity to spend a few months clinically in both South Africa and Madagascar, which is really what affirmed my desire to practice global health in my career long term. So then I came to Toronto for residency in general surgery, and I had the opportunity while I was doing my residency to take some time away to get research training in global health and population health methods. So I did my Master's of Public Health at Harvard, working with John Miura's group, looking at equity and access to safe, affordable surgical and anesthesia care. Mostly doing policy work and in terms of helping governments prioritize surgery as a critical part of universal health coverage and health systems.
During that time, did you stay in Boston or did you do any field work?
So most of my work was based in Boston. I did have the opportunity to spend a bit of time in Haiti, just doing some interviews for a case study that we were working on. But most of it was policy work that was based in Boston, with some travels for conferences, etc., but mostly in Boston.
Now you're in your final year of residency, and what's next for you?
So next I'm headed to Calgary to do a fellowship in critical care medicine. So I'm interested in taking an equity lens toward critical care as well. Critical care, like surgery was a few years ago, is not really a big part of the global health agenda. You know, it is a sort of highly specialized part of medicine that's fairly resource intensive. But I'd like to look at equity and access to basic life-saving measures from a critical care perspective and how those can be broadened and made applicable to more settings.
And could you outline maybe one or two of the really influential or good things that have happened to you in your pursuit of global surgery as a career, and if there's any things that have been negatively impact you?
So I think when I was in Boston, I had the opportunity to learn from a lot of really important people in global surgery, who really inspired me to stay focused on the work and to stay focused on the most important people in this work, namely the patients in low and middle income countries who currently lack access to surgery. So through that work, I had the opportunity to work with a number of people, bringing together a document on best practices for high-income country partners in global surgery, and the best ways for those in high-income countries to promote surgery as a critical part of health systems for those in low and middle-income countries.
You were the lead author in a pretty important paper on the roadmap towards global surgery. Could you just outline some of the conclusions that you come to for that? I think it was the roadmap for high-income countries for 2030.
Yeah. So it's interesting because that paper actually was a bit controversial in one sense, because folks were saying, why are we focusing on high-income country actors? The real action is in low and middle-income countries, and so we should be focused on on those actors rather than those in high-income countries. And in my mind, there's actually not a whole lot of controversy, because that's what we sort of argue for in this paper, that the most important actors and contributors to global surgery are the clinicians, patients, and policymakers in low and middle-income countries. And really, those in high-income countries should merely serve a subservient role to those actors in low and middle income countries, that we really need to be sort of humble about what we can and should be aiming for as high income country actors, when the real push toward universal access to safe and affordable surgical and anesthesia care has to come from within countries. And that's really what we concluded across different groups, from the press in high-income countries, from universities to individual clinicians, is that really we shouldn't lose sight of the big picture, which is the 5 billion people that can't access surgery and anesthesia care, and really making them the top decision makers and constituents in this work.
You were an example of it, but do you think a resident in surgery here in Canada would be of benefit? It would be a benefit to them to have a rotation in a global surgery setting? Yeah.
So, I mean, I think these are things that have to be done really thoughtfully and delicately. I think that there can be a lot of bilateral benefit even for clinicians in training in high-income countries to be exposed to the challenges of delivering high-quality surgical care in a low-income country setting. There's certainly the prospect for significant harm, meaning if high-income country residents are taking away training opportunities from low and middle-income country residents, or providing a standard of care that wouldn't be acceptable in a high-income country setting. But I do think that there is the possibility to really develop long-term relationships that can foster the development of health systems. A great piece of advice that one of my mentors in global surgery told me once is that on your first trip anywhere, your number one goal is to make a friend, to find a clinician in the lower middle income country setting that you really connect with, and that you can really develop a long-term working relationship with. So I think there certainly are benefits in terms of exposing high-income country trainees to existing inequities in access to healthcare. But I think that a significant amount of thought and institutional policy really needs to go into making sure that the benefit is indeed bilateral.
You touched on something with the making a friend, that you can create a word that's really in the literature quite a bit, and that is sustainability. And how are we going to reach that sustainability?
Yeah. So I think sustainability is sort of a two-sided coin. So on the one hand, yes, it's important that the things we aspire to achieve in low and middle income countries remain after our lifetimes and after our clinical work is quote unquote complete. But on the other side, sustainability can be used as an argument to not act. If you can't do something quote unquote sustainably, then you shouldn't be doing it all, which I think is problematic in a number of senses. First of all, because sustainability was used to exclude surgery from the global health agenda for decades. It was looked at as quote unquote not sustainable. But sustainability really is as much of a political argument as it is a resource one. So I think aiming towards sustainability in health systems means working at all levels, working at the government level to make sure that the things that are important to clinicians in low and middle income country settings are maintainable with funding, with resources from the government, and even sometimes from high income country donors, which can be sustainable depending on how things are set up. But I think that that really working at multiple levels, at the individual clinician level, at the institutional level, at the clinical college level, and at the government level, is important to making sure that the agenda for universal access to safe and affordable surgery is a long-term effort and not just a flash in the pan.
Okay. Do you think the principles in global surgery apply within Canada's borders?
Absolutely. And a lot of work has been done to date in terms of inequities in access to surgery in Canada. There's work on oncology in terms of access to transplantation, in terms of access to even like primary care services in Canada, and how these things can be inequitable by socioeconomic status, by geographic location, by race. So there's a lot of work that's already gone into that, but I think there's a lot more that we need to discover, mostly on solutions to these problems. So how do we equitably provide surgical services to those in the far north who live far away from the nearest surgical hospital? How do we equitably provide cancer screening services to under-resourced and marginalized populations like the Canadian Indigenous population? How do we achieve equity in outcomes even from surgery? So there's a lot of, I think we're becoming more and more aware of the problems with health equity and health access inequities in Canada, but where we still need to do a lot more work is finding out what the solutions to those inequity problems are.